Now we have almost covered most of the skeletal dysplasias. We have covered those diseases which are affecting the physis, such as achondroplasia and hypochondroplasia. We have covered in this section mostly the diseases which are affecting the epiphysis, such as skeletal spondyloepiphyseal dysplasia and multiple epiphyseal dysplasias. We have also covered the disease which is affecting the metaphysis, such as metaphyseal osteochondrodysplasia. Then we also went on those diseases which are not specific to certain region, but actually affecting the whole of the bone. Now we are moving to another group of diseases which are not specific to region as well, but mostly the bone is normal in terms of development, but the problem is the bone density, that either the bones are too brittle or too strong. In case of osteopetrosis, we will be going through two diseases called as osteogenesis imperfecta and osteopetrosis. One is called as brittle bone disease or osteogenesis imperfecta. Second is called osteopetrosis or marble bone disease. Now, these two diseases actually do not affect primarily any region, but the problem is with the altered bone density, that they are either too strong or too weak. In case of osteogenesis imperfecta, which is also called as brittle bone disease, usually it's a connective tissue disorder with mutations of COL1A1 and 1A2 genes. That is, type 1 collagen problem is always there, and they're actually based on 4 types. Usually its inheritance is autosomal dominant as well as recessive. On this term is usually divided into 4 subtypes, which could be based on the following problems, such as scleral involvement, whether the sclera is blue or not, natural history, and perceived inheritance. There are 4 subtypes which are mainly involved. Usually these childs, if you see this child, this is presenting almost all the features of achondroplasia. This is almost all the features of osteogenesis imperfecta. There is blue sclera, this short height, limb malalignment is always there. If you see this, there maybe this limb malalignment is probably due to multiple fractures. The classical presentation is usually a child of 5-6 years old comes to you with a history of multiple fractures previously, and probably the cause was due to maybe such trivial trauma. Most of the time they usually fall from the bed resulting in a fracture. These kind of things usually happen. Diagnosis is mainly based on the radiographs. There are multiple fractures, some of them in the healing phase, some of them fresh, and this is also reason. One thing, in these children you have to differentiate from abuse of the child at home as well. Sometimes if child presents you with multiple healing fractures, the first thing which comes to your mind is an abuse at home, but we have to differentiate from osteogenesis imperfecta from these kind of problems. The second is, once you know that most likely it's a skeletal dysplasia or something to affecting the skeleton, then we go for DNA analysis. That is, we go for COL1A1 and 1A2 gene analysis, and usually these receptors of these genes are not present in the analysis. The last way out is collagen analysis of dermal punch biopsies. Usually they will be deficient in type 1 collagen. Clinical manifestation, as I just told you, usually recurrent fractures with trivial trauma. There's dental abnormalities and dentine caries associated with sclera, which is usually bluish sclera discoloration. Spinal anomalies include scoliosis and kyphosis. There is associated degeneration, long standing malalignment, and painful osteoarthritis. And when you examine these joints, usually increased protein deposition in the joints as well is always present. This, if you see this X-ray, if you see this whole malalignment is due to multiple fractures. Probably the sub fracture was here, then it was here, and then here, then eventually it healed in such a way that leading to a kind of a malalignment. Enlargement usually seen of the frontal and mastoid sinuses. Thin cortices of the long bone, as you can see over here. These are paper thin cortices, especially over here. and Shepherd Cook deformity. If you see this, this is a classical picture because of a fracture which happened over here in the subtroch region. Then it healed in malalignment, leading to this kind of a deformity called as Shepherd Cook deformity. And there is a popcorn appearance of multiple areas. If you see this limb as a whole, this is multiple spiculated punctations is there, or whitish discoloration of the bone, which is due to popcorn appearance of multiple areas. Why this is happening? Because there is actually sclerosis at multiple areas and normal bone formation is not taking place. Management includes, as we know, it's a disease of type 1 collagen deficiency, and we have to treat the abnormalities which has actually been produced, if it's being produced in the spine or if it's being produced in the limbs. Management starts with the physiotherapy in the initial phase so that the joints do not get contractures, they remain supple and the ambulation is not disturbed. Then if a further step ladder pattern, if we are going in this, usually agents to enhance bone strength, which includes use of bisphosphonates because they actually inhibit the activity of osteoclasts. So although the bones are weak, but osteoclast activity, which is causing further bone resorption, is actually inhibited. Then there may be a surgical intervention. Surgical intervention includes when there is severe malalignment, in case of a Shepherd Cook deformity, or in case of those deformities which we have seen in the previous x-rays, the tibiae. Usually multiple osteotomies may be needed, sometimes at multiple level is needed. So depending upon what kind of abnormality is, then it has to be surgically managed. If it's in spine, sometimes anterior or posterior instrumentation infusion may be needed, and depending upon the kind of involvement and neurological compromise, then the surgical management is directed at them. Now we are coming to another disease of the same category, that is which affects the bone density actually, that is osteopetrosis, also called as Albers-Schonberg disease. In this actually the problem is with the bone is such that they become so hard that it's almost as hard as a marble. Abnormally dense bone, poor absent medullary canal formation, because so much cortex is there that medullary canal is almost absent in these diseases. Bone is still fragile. The reasons, although it's hard, but the problem is corrective tissue is not affected. As a result, it can break very easily. Bones need to be in a minimal density, that it needs to have some degree of elasticity as well as some degree of hardness, so that it can bend to its extent without breaking and then regain its normal position. But as the bones are so strong that they do not bend, rather they simply break, leading to increased fractures. It's a trait which is actually acquired as an autosomal recessive infantile pattern. And then there's two different types, which is congenital type or infantile type is autosomal recessive, while this called as osteopetrosis tarda, which is an autosomal dominant type, which is mainly in the adult. Clinical features are classical genovalgum, that is board legs, the bones have become strong and thick, and as a result there is actually blockage of these sinuses, leading to hydrocephalus sinus blockages, hearing loss, and cranial nerve entrapments, because the nerves which are exiting the skull through different foramina, for example facial nerve, crosspharyngeal nerves, these nerves get entrapped in these bones, leading to neuropathies. And obliteration of medullary canal, because in the long bones there's hardly any medullary canal which is seen. And then maybe osteitis of mandible may be present. Defective osteoclasts may lead to kind of a hard, defective, brittle bone. There may be associated increased parathyroid hormone levels, and sclerotic bones may also be present. Coming to the treatment, the first and foremost is giving them vitamin D, which actually stimulates osteoclastic activity. Gamma interferon, this enhances leukocyte function and increases bone marrow volume. Then erythropoietin is usually given to treat anemia, because as they do not have enough bone marrow for erythropoiesis, so they usually associated with anemia. So anemia can be corrected by giving them recombinant erythropoietin. Now steroids and normal bone actually decrease the bone mass. But as these are defective osteoclasts are getting proliferative, therefore steroids they cause increased bone resorption so that these defective osteoclasts are removed and normal bone is laid down. So in a way, it's kind of helpful for these patients with osteopetrosis. In this topic, we have covered multiple diseases. Now, the last one too was osteogenesis imperfecta and osteopetrosis. And these were the diseases which primarily not only affected any region, but the problem was with the bone density. In osteogenesis imperfecta, it's called as the brittle bone disease. The bones are weak and usually break with multiple fractures. In osteopetrosis, bone is strong, which is called as marble bone disease, but the problem is there's obliteration of medullary canals and multiple sign symptoms are actually coming due to obliteration of sinuses and exiting foramina through which the nerves exit through the cranial cavity. Thank you very much. Keep watching sqadia.com.